The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you for joining us today. The webinar will begin in 1 minute at the top of the hour. Again, thank you for joining us. The webinar will begin in 1 minute. Good day and welcome to this Health Catalyst webinar. As a quick introduction, Health Catalyst is a next-generation data, analytics software, and decision support company committed to being a catalyst for massive sustained healthcare improvements. My name is Sarah Stokes, and I will be your moderator today. Now let us begin with today's webinar, Population Health Management, Path to Value, presented by John Moore, CEO and founder of CHILMARK Research. After a 15-year career advising in the manufacturing sector, John launched CHILMARK Research to provide market-leading coverage of the most transformative sectors of healthcare IT. Throughout today's webinar, you will be presented with multiple poll questions. We encourage you to participate in these polls as they will help to drive today's conversation forward. We urge you to submit questions throughout today's presentation via the questions pane in your GoToWebinar control panel, as John will answer questions at the conclusion of the presentation in a Q&A session. We are recording today's webinar, and by midday tomorrow, you will receive an email with links to that recording, the presentation slides, and a transcript. If you'd like to stay in the loop on upcoming webinars and all things Health Catalyst, you can follow us on social media. Our handle is @HealthCatalyst. I will now turn the time over to John. John?
Thank you, Sarah. Hello, everyone. It's my pleasure to present to you some of the recent research that my company, CHILMARK Research, has been doing around population health management and how organizations are deriving value from their investments in population health management. So first off, I just wanted to give you a little bit of information about CHILMARK Research. As Sarah said, this is a company that I founded after working in the manufacturing sector for a number of years. Now CHILMARK Research is 12 years old. Our sole focus has been the healthcare sector. And we're really mission driven here, where we want, through our research, to help organizations adopt and deploy and use IT that will truly improve the patient experience and ultimately patient outcomes. Although outcomes aren't always good, the experience can be better than oftentimes what we're delivering today. We focus on those technologies that we believe will be transformative to the delivery of care, so that delivery care chain. And we try to, our values are really about providing the highest quality objective research in the market. So to begin my presentation, really want just to say, we now, all of us, live in a digital economy. Last summer when I was in China, everywhere you went, you saw this little Q code to scan. And everyone pays via their phone, even at a farmer's market such as this one. It's just the way you do business. There was at one point during my trip where literally a taxi driver could not make change for roughly $2. He did not carry any cash. He was using just the Q code for all of his rides. So this creates a new world order in the world today, where data is the lingua franca. It is, and organizations are becoming analytics enabled and intelligence augmented. And last, but certainly not least, there's the expectation that there's 24/7 availability to information. So when we look at population health here at CHILMARK Research, we really have always defined it as a data-driven strategy. And our definition has been for a number of years now, since probably 2012, the proactive management of the health of a given population by a defined network of financially linked providers in partnership with the community. So those are the three main points: proactive management of the population within a network of financially linked providers and in partnership with community stakeholders. And PHM, honestly, the reason organizations are doing this, it's simply in response to the initiatives that are taking place across the country since the passage of the Affordable Care Act with regards to value-based care and new payment models, reimbursement models that are hoping to increase the quality of care delivered and lower cost, thereby increasing the value of that care. So this is creating shifting risk from payers to providers, where providers are taking on more risk for the patient population that they are managing. We're moving to more proactive care models, and of course, to help reduce those costs and improve quality, reducing unwarranted variability in the delivery of care with evidence-based medicine. There's only one small problem here: who actually defines value? We'll talk about that a little bit later. So to enable population health management, to enable that strategy, there are really 4 core pillars. There is the enterprise data warehouse. That's kind of your foundation layer with the analytics, the algorithms, the AI, ML, if you're using some of that, visualization tools, etc., to really understand the population, track that population, measure its improving health or closing gaps, whatever the measures that are important to you, and then continuing to refine. The interoperability engine is how do you extract data from your EHR and across the multitude of others that you may have in your network and deliver insights back into clinical workflow once you've gathered that data and been able to generate insights. How do you get it back into clinician workflow, particularly in the ambulatory sector? Care management is certainly around managing particularly chronic care patients to lower utilization costs. And last but certainly not least is patient engagement and it actually enables self-care. And again, that gets back to lowering your utilization cost. And our view of population health is it's really a system of engagement. You have your system of record, which are basic software that is hosting processes, tend to be very hierarchical, transaction-based, long deployment cycles, etc. But when you look at systems of engagement, this is where you touch people. This is that outreach into the clinical workflow, out to the patient, out to the community caregivers, of creating information for them so to help them make appropriate decisions with regards to their health. And ultimately, that rolls up into managing the population of the region or community that you have responsibility for. So a quick poll question for you. What is your organization's biggest challenge in enabling its PHM strategy? These are ones that are commonly referred to, but I'm really curious as to here in the audience, what are your own organization's challenges?
All right, thanks, John. So we'll give you all just a moment to respond to this poll question. Your options are cultural readiness, engaging community resources, patient caregivers, financial resources commitments, accessing and aggregating data, and then immature IT infrastructure or solutions to enable PHM. And again, if you joined us late, we are recording today's session. You will have access to that tomorrow. We will email out a link to that as well as to the slides. All right, the votes are still pouring in. I'm going to go ahead and close that now and share the results. All right, so 16% reported cultural readiness, 15% reported engaging community resources, 18% reported that financial commitment or resource commitment. Your majority here, 27%, reported accessing and aggregating data. And then the second highest, 23%, reported immature IT infrastructure or solutions to enable PHM. So does that line up with what you would think, John?
To a bit. I'm a little surprised, honestly, and I understand certainly the accessing and aggregating data. That is a real big problem today. The immature IT infrastructure is a little surprising, and in some of our surveys that we've done, we've usually found that the cultural readiness has been a challenge for a lot of organizations to get them really engaged. Oh, gotta go up one. Sorry about that, folks. So when we looked at the population, we've been following the population health management space and the market of solutions that have been delivered since, oh gosh, since about 2010, 2009, 2010, when it first came on the scene. And what we saw first was really kind of a population health 1.0, very incomplete solutions. They were primarily built for payers, almost exclusively. And then they tried to shoehorn them into the provider market. They were all claims driven. It was really about gaps in care and basic reporting and very limited analytics tools. And it was all for, the payers, they're looking to reduce the medical loss ratios. There were absolutely no patient engagement capabilities with these solutions and no community engagement as well. When we got to Population Health 2.0, that's been happening since about 2012. Solutions started to come into the market that could address a number of the needs that a given organization would have to meet, those 4 pillars that I said earlier. These companies started to bring those types of solutions to meet a lot of that. They're really combining multiple data sources, not just claims data. They've got some predictive analytics capabilities, better visualization and drill down tools. And they're really improving the delivery of the insights into clinical workflow, oftentimes in fairly closed systems. Within an acute setting, it's still quite difficult to do that in the ambulatory sector when you have a heterogeneous EHR environment. PHM 3.0 is what's going to be coming. We see this as being a market agnostic solution. It will be delivered to payers, providers, employers. It really will be a true open API platform ecosystem built atop a robust analytics engine and engage the full continuum of care. So when we think about Population Health 3.0, this is kind of the model we have today that we've created to look at this. As you see at the bottom, you have your systems of record, all those various data sources, like the IoT, could be wireless, health devices, wellness, what have you, Apple Watch, could be anything coming in, or home monitoring. But all that's being fed up into the EDW, where the data aggregation and normalization occurs via FHIR and other open APIs. You then layer in your analytics and visualization, and then you have the FHIR APIs to deliver those insights into a wide range of various applications that are designed for particular needs, like for chronic disease management, utilization management, community engagement, patient engagement. These various smart on FHIR apps will be enabled from this platform as a service, Population Health. So who brings Population Health 3.0 to market? Well, I honestly see it kind of, the big infrastructure plays of Amazon Web Services, Google Health, and Microsoft Azure today. They will be kind of the infrastructure that will enable Population Health 3.0. All 3 of these have massive scale. All 3 of them are FHIR enabled today. They are HIPAA compliant. And each of them have an increasing array of their own MIML tools that developers can use to create those, for example, smart on FHIR apps, potentially. Last week, I believe it was, Cerner had an announcement of a partnership with Amazon, extending their partnership with Amazon, not only just Amazon Web Services, but Amazon proper. And it remains to be seen that might look like in the future. An interesting arrangement, and Amazon certainly has its sights set on healthcare. Health Catalyst, on the other side, has been using Microsoft Azure for a number of years now, which is a very, very solid platform and favored by a lot of other healthcare vendors. So I think those are kind of the two big ones right now, AWS and Microsoft Azure. Google's playing catch up. So when we look at population health, we said it's a data-driven strategy. Analytics remains a challenge, as we showed in the poll. When I said people responded, one of the things we have here is data quality and latency, getting the data. So that's the third item we have here, and that's certainly an issue that organizations, we continue when we talk to organizations and work with them, find that aggregating the data, cleansing and normalizing the data is a huge issue. And a lot of the tools today simply aren't mature enough to do that as readily and easily as one would like. But we also have establishing a clinically integrated network, particularly on the ambulatory side, and how do you get insights into workflow at the point of care. End user trust, and what I mean by that is end user trust could be that case manager, it could be the clinician, the doctor. You have to give, if you're going to be telling them what is the best thing to be doing for that given patient or the population that they serve, you have to make sure that the analytics have transparency to them so they can actually see how you derive those answers. So to get engagement, you really have to establish trust. And that transparency is critical. The immaturity in the market today, frankly, in the healthcare sector, there is a dearth of analytics, especially within the mid-sized to smaller hospital systems. And patient-reported outcomes remains weak. We still don't do a good job of that. Actually, I think we do a terrible job in this country today. And social determinants of health, we're just getting started. So the migration to value-based care. We've had over the years a very slow migration to risk. So, this all got started with the passage of the ACA, but if you look at the percent of payments in 2017, those that had any downside risk are listed in category 4. Not a heck of a lot in payments is being made that includes some form of downside risk. So most of them have been, category 1 through 3 have been basically your standard fee-for-service or a fee-for-service chassis with some quality metrics added to it and maybe some cost targets as in category 3. And this was a recent survey done and released in March of this year, where in the state of population health, and they've been doing this survey for 4 years now. And back in 2016, they asked what were organizations' predicted readiness to assume risk by 2018. Well, what they predicted in 2016 and what their actual readiness is to assume risk in 2018, it went from a 61% confidence rate to 25%. Organizations today are still really struggling with their ability to take on risk, especially downside risk in these new payment models. So, poll question for everyone. What percent of your organization's projected total revenue in 2019 is tied to value-based contracts?
All right, great. Thank you again, John. All right, so your options on this poll are number 1, 0 to 5%, 2, 6 to 10%, 3, 11 to 20%, 4, 21 to 35%, and your last option is greater than 35%. And based on what you shared, John, I don't know how many are going to fall in that category, but maybe we'll get a few. All right, we'll leave this open for just another moment now. This one is a little bit more of a thinker, asking you to pause and think about your own organization. Again, as a reminder, we are recording today's session. You will have access to that recording. And we do encourage you to submit your questions throughout the presentation. John will be addressing those in a Q&A at the close of today's session. All right, we're going to go ahead and close that poll and share the results. All right, so it looks like the majority, 37%, were in that 0 to 5% range. 24% of people reported 6 to 10%. 15% reported 11 to 20%. 9% reported 21 to 35%. And 15% came in that greater than 35% area. Again, John, what do you think about these results?
Those are definitely what is expected. We've been tracking this for several years now, looking at the shift to transition to value-based care reimbursement models, and it still represents a very small proportion of total revenue, which again, that turn challenges for organizations in their shift to value-based care. So, as we saw on the poll, fee-for-service is the primary source of revenue for most organizations. We kind of peg, nationally value-based care revenue and provider organizations at less than 15%, and the recent poll basically confirmed that. With this, and part of the problem, I don't really blame providers for this kind of slow migration to risk, because there's been a lot of market uncertainty. I mean, how many times have we heard about the desire to overturn the ACA/Obamacare? This regulatory uncertainty, was then manifested in organizations basically sitting on their checkbook. They didn't want to make a commitment to population health and value-based care until they had clearer signals from Washington and the payers in their market that this was where we're headed, or is where we're headed. And it's not trivial. Value-based care requires a significant restructuring within the organization. It requires a pretty big cultural shift. It requires quite a bit of resources, and it does require, the most senior executive commitment, because at the end of the day, some of the things you do in value-based care may directly impact other operations within the hospital. For example, if you are focused on reducing ER admissions, then the ER's revenue source is decreased. If you're trying to lower length of stay in hospitals, then that decreases revenue for the hospital with regards to length of stay. So it really depends on a number of factors here that have created, a continued uncertainty in the market and this slow movement to risk. So in our research over the last year, we've been doing some significant research here in this area, again, looking at the value for PHM investments. What we found is that, amongst the organizations we've interviewed, we've done web surveys, and we've had focus groups, is that about 5% are the true innovators. They have a very strategic focus on population health. They see the ability to become value-based focused as a core competency for the entire organization. There's no question, value will be their core competency, and they will deliver higher value to the communities they serve than those in their competing market. There is a strong focus on cost because they've already assumed quality is a given. So now they're really turning their sights to looking at how do they structure their cost profile. When we look at the early mid adopters, we find them very process focused. They're really looking at workflow. They're looking at how do we get insights into the point of care and kind of enable the physicians, the clinicians, the community to make the right decisions in taking care of the population being served. What's interesting about this group, or particularly more the early adopters, is that they're moving to contract agnostic measures. And what I mean by that is that every payer that you may be working with as a healthcare organization, when they come to you with a value-based contract, they're going to have different quality metrics than the last payer that came to you, or CMS, or whoever, or the employer. So what these organizations are doing, they're saying, okay, we will adopt a baseline of agnostic measures that we will accept. Strict but reasonable quality measures. And once they settle on that benchmark, if a payer comes to them with measures that exceed those, what they believe are already very good measures, then they will simply walk away from the contract. They will not accept it. They will wait for the payer to come back. There's less of a focus on cost. It's all about the quality for those early mid adopters. And finally, we have the late adopters. They're very tactically focused. And what we mean by that is they're moving at a very contract by contract approach to population health and value-based care, typically starting with their own employee base. So what we have now today, surprisingly, in this administration, is a very activist CMS and HHS. They have really been pushing for providers to take on risk, which this particular administration and HHS and CMS are more activist than the previous one in getting providers to take on risk. The most recent rules for the MSSP, Medicare Shared Savings Plan, ACOs, is the pathway to success, and providers are only given 1 year of basically going at no risk on these contracts, just upside, and then after the first year they have to assume downside risk as well. So there's no more of this, 5 years for you to figure out how to do it. You have to figure it out how to do it in a year. They've also, have proposed more flexibility via waivers, which I think is a good thing. So organizations can be a little bit more flexible with what they, how they meet these guidelines. There's talk about relaxing the Stark law. They've made a couple press releases. They've made some mentions of this, but it's still, and that was about a year ago, but it's still being discussed. There's been nothing conclusive that's come out of HHS with regards to the Stark law. But you also have several states, including my own here in Massachusetts, that have moved to a capitated model for Medicaid. We also see growth in Medicare Advantage. If you remember back to that slide where I showed category 4 and how little at risk there was, that was downside risk. The one that was paying out the highest revenue in that particular category 4 was Medicare Advantage. This is a very hot market right now for a number of reasons. First off, over 50% of new beneficiaries are choosing Medicare Advantage. And that's the baby boomers. It's also creating acceleration of partnerships between providers and payers. Payers are actively looking for those providers they can partner with to create a partnership for Medicare Advantage. And it's really about improving HEDIS scores, because if you get those HEDIS scores up and you can maximize the bonus and hit 5 stars, you score big. You score big. If you're at 3 stars, you're losing money. It's really the key driver for what we believe is what we've been talking about quite a bit here at CHILMARK Research, is provider-payer convergence, how providers and payers are coming closer together to actually meet the requirements of things like this. For example, the partnerships JVs that Aetna has established with 5 different large provider organizations across the country is a case in point. United Health Group and their expansion through acquisition of their provider network, most recently by acquiring the ambulatory physicians of DaVita. And of course, there's a blossoming of new entrants all looking to capitalize on Medicare Advantage. These are all relatively new payers of one form or another, including Bright Health, Clover Health, Devoted Health, which is actually one of the founders is Todd Park, who helped found Athena Health, and Oscar Health. We also have employers driving value-based care as well. This was in a recent report by the National Employers, I forget the whole acronym, but anyway, the survey that they did of their employer members found that employers are looking to support ACOs, basically doubling what they do today to nearly 50%. And they're also increasing direct contracting with providers, particularly those that have high performance networks. And high performance networks are those that can deliver value. So getting to the final part of the presentation here. So what's the path to value for population health management investments? Well, as I said, we've been doing quite a bit of research in the past year on this particular topic. We've run a number of focus groups, we've done some web surveying, and what we have found is that value is the big elephant in the room. Depending on where you're touching that elephant, you'll have a different description of what that elephant is. And the same holds true for value. It depends on where you are in this country. The local and regional stakeholders, that being employers, payers, etc., will define the value equation for your region or the area that you serve. But that value is anything but consistent across the country. So one of the things we did was, this kind of gets to, well, we asked, so have you realized any ROI from your population health investments? And 22% said, yes, we have. And another 11% said, yeah, well, we project it within the year. So, roughly a third of people say, yeah, they realized ROI from their population health investments. The funny thing is, people don't understand what ROI is. And I think maybe we worded the question wrong. I'm not sure. But when we actually drill down and start asking them how do they define ROI, what we really found was they're not including sunk costs. They're not including all the PHM investments they've made to date. They will turn instead say, yeah, we hit our bonus, whatever that may be, and we're feeling really good about that. Is it paying for itself? We've yet to find an organization today that says that their population health management solution ROI is greater than the investment than they made. So it's not paying for itself yet. So we do see it trending in the right direction. I think as organizations fully commit to value-based care, that this will change, that this will flip. It's kind of reminds me, as you remember back to the slide I had of the person in one foot in the boat, one foot on the dock. We had a speaker once, the CMO from Geisinger, and the title of his presentation was Burn the Boats. And his argument was, you got to make a full commitment to value-based care. You got to just set sail, get to the other side, and then burn the boat so you can't return back. So the big challenge with ROI and determining ROI, when we further drill down in our questioning with organizations, particularly through our focus groups, is that we found that value is very much a moving target. It shifts by the year in terms of what payers are defining as value, what they're looking to obtain from a given organization. Even CMS was quoted a couple times by organizations as being one that you never know what they're going to come up with next, yet there's not a lot of consistency. So this makes it very difficult to create a roadmap and creating a repeatable way to track cost and revenue to actually understand what the ROI is. But despite all that, the majority of the people we've spoken to, they're motivated to continue. They really don't see there being a choice, that value-based care is inevitable, it will come to pass, and that to remain competitive in the markets they serve, it's imperative that they move in this direction and continue to make the investments. And one of the things we've created here at CHILMARK Research that I think is important for organizations to take a look at as they consider their own value chain and how they deliver care is we created this value chain model, which actually we believe can help organizations at least begin the mapping process of how they would approach population health and ultimately value-based care. So in getting to the end here, One of the, in these focus groups that we've been having, we concluded those focus groups by, asking what are some of the best practices that they've developed since they've launched their population health initiatives. Pretty much it was unanimous. Everyone said, if you're going to begin down this path, begin with Medicare Advantage. It is a good growth opportunity. It has the lowest barriers to entry. Typically, you can find a payer partner that will help you along the way with identifying risk, helping you with gaps in care, et cetera, to actually capitalize on the bonus and hit those various targets that are embedded within a Medicare Advantage program. Another really interesting finding that was stated by a couple of organizations, well, several organizations actually, was how they focused on acute first for their population health program and initiative. And what they found was that's not where the value was. It was a lot of ways. It was easier to do because it was in kind of self-contained within a given defined entity, but it wasn't terribly valuable. It did not deliver value to the organization. Where the value is your focus on ambulatory and getting your ambulatory network, that high performance network, in sync with the objectives that are outlined in a given value-based care / population health management strategy. Another important point that was brought up was leverage registries, not based on, diseases, but really on utilization. Look at the utilization numbers. And once you do that, focus on the 3 to 10% of high utilizers. The reason for that is typically your first 1 to 3% are those you really can't do much about. They have some sort of serious chronic condition, like a cancer, for example, and there's not a lot you can do with that. Their journey is set. But below that level is you have your high utilizers and frequent flyers that you can do something about. And what you need to do is, once you've selected them, you need to find amongst that patient population that you've sorted out, who has the ability to self-manage. That's how you're going to lower your utilization costs. And lastly, simplify the physician burden. As we mentioned earlier, those that are kind of the early adopters are standardizing on the strictest reasonable measures. Not all measures are reasonable, so don't accept those that are considered unreasonable. And you have the knowledge and clinical staff in your organization to actually define and defend what are reasonable measures. And lastly, seek out operational efficiencies alongside your program. Always look for where can you have, drive operational efficiencies across the organization, across your network, across your community. So what to expect going forward? Certainly increasing clouds, population health, and the solutions therein will become an IT-enabled services play. They will move to the cloud, and you will have such things as analytics as a service, network design as a service, etc. And that's simply because a lot of organizations do not have the resources to hire the best data scientists, to hire the best talent in the market, whereas if it's provided via a service, then they can actually enable their strategy much more effectively. You'll see EHR vendors take the lion's share of the market. The simple reason for that is that in most cases they're in the workflow of a clinician. Unfortunately, they cannot solve all the needs. Their extension into the community is quite poor, and their data aggregation and management capabilities also remain immature by and large across the EHR vendors. They have done tremendous amounts of improvement over the years since when they got started, but they got a late start in this. And they're still playing catch up to some of the best of breed vendors that are out there today. Another thing that you really have to think about, and this was also a best practice, by the way, is your vendor has to become a partner. You have to work together on this. The only way you're going to succeed is if that vendor is truly hand in hand in partnership with you to ensure your success. And lastly, ROI will remain elusive, and value will not coalesce at a national level. It will coalesce at a regional level. So really pay attention to your region, to the competitive market that you're playing in. That's where the value will coalesce, and that's where you'll need to develop your best practices within that at that regional level. So I always like to close with a quote. This is one of my favorite, from David Blumenthal, Dr. Blumenthal. We are only as good as the information we have delivered at the point of decision. Thank you.
All right, great. Thanks so much, John. Okay, we have a couple of closing poll questions before we dive into this Q&A with John. So I'm going to go ahead and launch this first one here. Okay, before we move into the Q&A, we want to make a mention quickly of the Healthcare Analytics Summit, which is coming up. We're going to be doing a few giveaways here for passes. This is an annual event with more than 1,000 provider and payer attendees occurring September 10th to 12th in Salt Lake City, Utah this year. And we're going to be featuring brilliant keynote speakers from the healthcare industry and beyond. If you know that you're able to attend and are interested in being considered for complimentary passes for a team of 3 to attend the Healthcare Analytics Summit, please answer this poll question. We'll give you just a moment there to get your responses in. Once you have submitted your response here, we do encourage you to submit those questions for John as we are rapidly approaching the Q&A session. All right, I'm going to go ahead and close that poll, then move on to our second. All right. If you know that you're able to attend and are interested in being considered for a complimentary individual pass to attend the Healthcare Analytics Summit, please answer this poll question. So maybe not your whole team is able to travel during that time, but you are. We encourage you to, again, respond to this poll question here. I'll give you just a moment. All right, we're going to go ahead and close that poll. And then we have one final poll question for you all, which we will leave open as we dive into the Q&A. All right, while today's webinar was focused on population health management and the move to value-based care, some of you may want to learn more about the work that Health Catalyst is doing in this space, or maybe you'd like to learn more about our other products or professional services. If you would like to learn more, please answer this poll question. And again, we're just going to leave that open here as we dive into our Q&A questions. All right, you ready, John?
I'm ready.
Okay, our first question comes from Juan, who asks, are providers able to manage and understand risk in order to agree with the capitation payments with payers?
Yes, of course they are. You have to educate them. You have to tell, it's like anything in life. It's to a certain extent, what's in it for me and for my patients that I serve. And an organization needs to articulate that to the network that they've defined that will be working with a parent organization to deliver value-based care in the community.
Okay. Next question comes from Edward, who asks, what are some examples of innovators in a VBC adopter?
Okay. I think innovators, oh gosh, where to start? I mean, Kaiser Permanente, they've been in a capitated care model forever. So they've been at this for quite a while. And Group Health up in the Pacific Northwest, which surprisingly, or not surprisingly, Kaiser ended up acquiring, was also an organization that was very forward-thinking with regards to this. Geisinger has been at this for quite a while in central Pennsylvania. UPMC, who has their own health plan with, I think they're over 8 million members now in their health plan, has also been fairly progressive, on this. I would also point to Atrium Health down in the Carolinas, They've also been very forward thinking with regards to this. And lastly, even in the backyard of Health Catalyst, the host of this webinar, is Intermountain. And Intermountain has also been doing quite a bit of work in this arena. And of course, if you go back to Brent James' work on quality and cost, some amazing work they've done in the past in this regard, moving towards value.
Okay. This next question is, any thoughts on data collection of social determinants of health and what can be used to collect that much needed data?
Well, I think, with regards to social determinants of health, it really starts with basically with the clipboard or the kiosk or whatever you're using to collect patient information upon their clinical visit or exam room visit or yearly visit, just asking them where they're at, and also doing that in person, potentially between the clinician and the patient, and really focusing on what is the financial security, housing security, and food security of a given patient. Not to say that all patients will be forthcoming, but that's where you start. Beyond that, there's certainly census data. There's the hot spotting that has been done in the past, particularly in Camden, New Jersey. There was some great work done there. But it's still going to be, excuse me, challenging to collect this data. We are literally just getting started, and there are honestly no easy tools to do this. The only things that I've been seeing to date are those embedded directly in the EHR as part of the workflow.
Okay. Next question comes from Joan, who asks, you mentioned health providers partnering with health payers. Are there any successful examples or models of this?
Well, it's all fairly new. It certainly has been successful for some organizations. Humana has had a number of partnerships with various providers across the country, in which around Medicare Advantage in particular. As I mentioned, Aetna has 5 JVs with large hospital systems such as Banner Health, Sutter, Allina, Texas Health Resources. So you do find examples of that at some of the local level, kind of at the say the Blues in a given region or state. We haven't seen as a proactive, aggressive approach among the Blues to move in this direction. And it remains to be seen exactly what they will do going forward. Certainly, some of the larger conglomerates like an Anthem are beginning to do this as well, but they have not been quite as progressive as the commercials.
All right, next question is, do you find that PHM efforts are stalling because available tools and technology are not working, or maybe they're lacking in function, or is it more cultural issues such as a lack of proper internal support?
I really think it really depends on, I think it's a little bit of both. I would lean a little bit more heavily on getting internal buy-in across an organization to accept this is where we need to go and what we need to do, because as I mentioned earlier, value-based care, some of the metrics and measurements that you're doing there actually could potentially hurt the revenue of a hospital system that's highly dependent on acute care, unless they have more admits than they can adequately deal with, because they simply don't have enough beds, and no one's in a mood right now to build more beds and more wings to hospitals if they can help it. So I think in that regard, that's certainly the bigger piece of the puzzle. But secondly, I do believe that we still do not have the robust tools that are needed to be fully successful And, I mentioned those 4 pillars of patient engagement, care management, interoperability, and analytics/EDW. Each of them have their challenges, and none of them, I would hazard, well, I'll just leave it at this. No one has the complete picture and a robust, all of those in one solution that's highly robust. At least not today. They're working on it, but it's not there today.
All right, next question. Which group do you believe has the greatest power to advance VBC adoption? Employers, providers, payers, etc.
Well, I think, right now it's really been CMS and the government that's led the charge on value-based care. It's highly dependent on where you are in the country as to how aggressive payers are moving in that regard. For example, during the focus group that one of the focus groups that we had, a provider organization in Georgia has found it extremely difficult to get clinicians on board for value-based care. And the reason for that is that the #1 payer in Georgia is Blue Cross Blue Shield. Blue Cross Blue Shield of Georgia has not a single value-based care contract. So when United Health or Humana or whoever else of the commercials come to the providers and say, hey, let's do Medicare Advantage together, they really don't care. They haven't been acclimated to the whole concept of value-based care, and there's little desire to move from fee-for-service because it is going to be painful at first to move in that direction. So I think, when I was talking about value, that's a perfect example of value is defined at the regional level. And if your leading payer in a given state or region is not on board at all, it's going to be very difficult to get clinicians on board.
Okay, this next question comes from Krish, who asks, what are the medical centers and payers' approach to PHM and VBC? Are they thinking of integrating claims with EHR to get better assessment of treatments and advanced detection?
Well, that's what, like I said, in Population Health Management 1.0, it was strictly claims driven. It was really, I used to call it fee for service and drag, because all it was just addressing care gaps, identifying care gaps from claims data and addressing them, which generate a fee for service, DRG, what have you. So, that's what happened. We've been moving steadily. Everyone realized claims data has a number of issues with it. It's not terribly clean. Providers will oftentimes put in whatever diagnosis the closest fit, not necessarily what the patient actually has in a claims submittal. And then lastly, there was latency in claims data of 6 months potentially. You just didn't get it from the payer fast enough to actually make a difference in dealing with the patients that you were managing. So that's why there's been this big push to bring in the clinical data. You get richer data, you get more accurate data and assessment of where the patient is truly at today, and you're able to make better decisions. Now, that's not to say you don't need claims data. You still need claims data for all those visits a patient may be doing out of your network, and you need to know where the patient's gone and what has happened. But that's where the claims data comes in. So it's really both. And as an organization progresses in the maturity of their move to population health and value-based care, it starts with some claims data, then they add the clinical in, and then you start adding the operational financial data to really understand what your cost structure is.
Okay, and maybe this next question kind of ties off on that. Catherine asks, for those orgs who are managing claims data, what do you recommend to be able to handle the data in a more efficient manner?
Oh boy. Okay, well, I'm not sure what exactly Catherine's asking in terms of handling data in a more efficient manner. Does that mean data ingestion and normalization, or is it data presentation and visualization? If you're looking at aggregation and normalization, it's just heavy lifting today. The tools still remain very immature for data aggregation and cleansing. There are some best of breed vendors out there, small best of breed vendors that I know of, that are focusing on just that problem, cleaning the data before it goes into the EDW. But it's a fairly new market, and those solutions are not widely distributed today. And then you look on the other side, if it's the visualization side of things, there are some really nice tools out there, whether, for example, Tableau has some great visualization tools that an organization can use to drill down on the data and actually understand what the data is telling them.
Oh, and John, she did come back and say that she was specifically asking around aggregation and normalization in that claims data.
Yeah, okay, aggregation and normalization. I hate to break it to you, Catherine, but the solutions aren't there yet. There are a few little best of breed vendors looking to tackle just that problem, but it's still not, it's not where it needs to be. I'll just leave it at that. It's still a lot of heavy lifting for most organizations, for all organizations, actually.
Okay, great. We just still have 5 minutes till the top of the hour, and we have a few more questions coming in, so we're just going to keep moving along as long as you're okay with that, John.
I sure am.
All
I'm
right.
committed till 2.
All right. This next question comes from Rebecca, who says, I have been in PHM for 8 years and have found EHRs to be horrid with respect to clinical workflows in an in-home clinical model. How far have EHRs come in being able to reverse flow the clinical workflow?
That's a great question, Rebecca. They haven't gotten close. Honestly, it's what I see as we've done a good job by and large of getting those workflows in an acute setting established. They're not great, but they're there. We're improving in our ability to distribute those workflows and enable those workflows, and as well as the insights and information across a distributed network of clinicians primarily, whether it's specialists or primary care or what have you, in the ambulatory sector. The next big bridge for the health IT industry, in my belief, is how do we extend this into the community? No one in the community is going to want to look at an EHR. They're not going to want to deal with Epic or Cerner or NextGen, any of those things. They need to have a very trimmed down, clean version of the information they need to help guide a patient, or for a patient to self-manage what they've got, whatever disease that may be, and do a better job of it and feel more enabled and empowered. Today, we're far from it. And it's sad, honestly. I've always hoped we would be further along than we are today. But frankly, it is what it is.
All right. Our next question comes from Bianca, who asks, what variables influence networks, ergo UPMC, to progressively integrate a Part D plan?
I think that's about beyond my pay grade to answer, in terms of the specifics of a Part D. I'm sorry.
Okay, we're going to do 2 more questions. This question comes from Krish, who asks, has machine learning started playing a big role in integrating data, or would you say it's still in its infancy?
Very much in its infancy. There have been some interesting studies and research projects in this regard. There was one that Google's DeepMind did with regards to EHR data that was I think that was released last year, the paper. But it's still very early on. There's nothing that I've seen yet that's truly a product that can enable that today.
All right.
It's research and research funded grants.
Okay. This last question that we're going to end on is an ambitious one for you, John. It comes from Vinod, who asks, when, in your opinion, will the shift to VBC be near complete?
Well, that's a tough one. One of the things that I've learned about healthcare is it doesn't necessarily move fast. And you have a lot of stakeholders here in this industry with a lot of varying interests, financial interests, and it's a follow the money type of game as to how quick this will transition. I do believe, though, that for those organizations where VBC revenue, particularly at risk, when they go at risk with downside risk, when it reaches, I would say 20% of revenue, that's significant. That basically represents about a point of margin for any healthcare organization. And when you get to that, representing a point of margin, you're going to start doing something and you're going to go all in. So I think, once we get to that inflection point, we'll start to see a cascade of organizations really aggressively moving in this direction because they need to, and they have to in order to compete in the markets they serve. They'll just be, they won't be able to compete going forward, except maybe in rural areas where it's just a single hospital. And even then, it remains in question. In terms of a time frame, I would say probably by 2023 or 2022, I would see us hitting that 20% inflection. It would probably be another 5 years after that before we really had a full commitment to value-based care. You're still going to see fee-for-service out there. It's not going completely away, but it'll be an increasing smaller percentage of how care is paid for today or in the future in the United States.
All right. Well, it is officially, we've passed the top of the hour, so we're going to wrap up the Q&A with that. We want to thank you, John, for taking the time to present to us today. And we want to thank everyone who joined us as well for making the time. Please do us a favor and complete the short survey as you all exit the presentation today. Your answers will help us to deliver more valuable content in the future. As a reminder, by midday tomorrow, you will receive an email with links to an on-demand recording, the presentation slides, and a transcription. We'd also like to invite you to join us for our next webinar, Getting to the Wrong Answer Faster with Your Analytics, Shifting to a Better Use of AI in Healthcare, which will be held next Wednesday, August 14th. This presentation will feature Health Catalyst's Chief Data Scientist, Jason Jones, who will walk through scenarios that illustrate how commonly used analytic methods can lead analysts and leaders to the wrong conclusions, and share how to course correct if this happens to you. We hope that you will join us for that. On behalf of John and all of us here at Health Catalyst, thank you for joining us today. This webinar is now concluded.